Hope everybody has had these 2 minutes just to be prepared to the session. So it's a great pleasure just to present this 1K Europe We Talk. My name is Sarah Ares. I'm the chair of the Working Party on Policy Advocacy, and it's my pleasure to be here with two family doctors who are working at the OECD in Paris. So we are going to discuss today about elevating the patient's voice, OECD Patients Report Indicator Service, PaRIS study, and its value for family doctors. So it's an honor to have here Candan and Angel. I'm going to start introducing Candan. She is, as I said, a family doctor. She has experience in primary care, in emergency care, and she conducted research at the French School of the Public Health. She is working at the moment as a OECD Health Policy Analyst, and her specialization is regarding the health policy, health system, management, and social and behavioral sciences. And she has been working for lots of years in this area, so she's an expert. And it's with great pleasure just to be able to talk about the PaRIS study. She's leading this study with a team from the OCDC office, and she has an important role just to connect family doctors with the methodology and also with collecting the information of the study. So Candan, we are very pleased to have you this afternoon here.
Thank you, Sarah, for the nice introduction. I see many familiar names in the chat as well. Welcome, everyone, and hopefully we will have a lively conversation today about the OECD's Paris work.
That's lovely. So many of you have met before Candan, and she will be answering a few questions later and just sharing a little bit what is the future for the PaRIS study and how we can connect with her and connect with this amazing study. And it's also with great pleasure just to introduce yourself to Angel Gonzalez. He is a family doctor. He also has an academic background in epidemiology, health economics. He has an MBA, and he has been working in the last 10 years in national and international research and also policy questions related to clinical, primary care, public health, academia, health systems, policy consulting, a little bit of everything. So I would say he's a very family doctor because he has done everything as real life, what we do in the normal consultation. So it's a great pleasure just to come with you. And Angel, he's going to share the results of the study, and he's going just to give us a little bit of the big perspective and big picture of what happened with the PaRIS study and which are the things that we can learn and that can be useful also for us as a family doctors. So as I said before, welcome everyone. It's very nice to see we have people from Denmark, Ukraine, Scotland, and so everybody is super welcome. If you have questions or comments, please just put it in the chat and we will be happy to address them and to have a great conversation. So Angel, I pass the mic to you. So thank you so much, both of you, for spending this afternoon with us. Thank you very much.
Okay, thank you very much, Sarah, for the introduction and also for the opportunity to present in front of Wonka Europe the PaRIS results through this webinar. And also, Sarah, thank you for being so proactive with the PaRIS project, because Sarah is part of a network of primary care professionals, stakeholders, and they are doing a great job in improving the PaRIS project. So thank you very much. So for today, we have elevating the patient voice, OECD's patient reported indicator surveys, PaRIS, and its values for family doctors. So we have tried to prepare a presentation that looks at the PaRIS results from the perspective of primary care and more specifically family doctors. First of all, an introductory slide on the work that we do at the OECD. So for those of you who don't know about the OECD or know very little, so it's an intergovernmental organization. Currently, we have 38 member countries. We do economic analysis for better health and health systems. We do international data collection and harmonization. So we try to do cross-country comparison through gathering data and policy mapping, policy surveys. And that's the way that by analyzing these indicators, we end up doing evidence-based policy advice. And what we try is to bring together different stakeholders, governments, experts, academics to find solutions for complex problems. And both Candan and I, we worked in the health division of the OECD. As you can imagine, we looked at health systems from different perspectives, also public health, health workforce, pharmaceuticals, so many different topics. So to start now with the PaRIS project, so we know as family doctors that healthcare is all about the patient, but we felt the rationale for the PaRIS project was that if we do not ask patients how healthcare impacts their lives, policy decisions are basically shots in the dark. So what PaRIS provides is a unique set of data and healthcare performance indicators from the perspective of those receiving care, that are the patients. At the right side of the screen, you can see the PaRIS flagship report, which was launched in February 2025, the 20th of February. Does healthcare deliver? Which you can find online. And well, the current status before PaRIS is that, yeah, we had made significant progress on health data collection, but still there were limited insights into patient-reported outcomes and experiences. And we felt that with PaRIS, we were filling a critical gap by adding data on health outcomes and care experiences that were taken directly from patients. So what's PaRIS? So PaRIS is 19 countries that pioneered during the PaRIS first cycle. And these 19 countries were more than 107,000 primary care users aged 45 and older, and more than 1,800 primary care practices. So this is the first cycle of the PaRIS survey. More than 100,000 patients and more than 1,800 primary care practices. And we were measuring two different types of patient-reported indicators. Patient-reported outcome measures, PROMs, which are report on the status of patient's health condition that comes directly from the patient, and patient-reported experience measures, PREMs, which are patients' views and observations on aspects of healthcare services that they have received, including their care from doctors, nurses, and other healthcare staff. And we came with the PaRIS 10 key indicators. So we disseminated a big comprehensive survey to patients, but in the end we decided to go with the PaRIS 10 key indicators that we thought that it was giving us a very interesting overview of every primary healthcare system, again from the perspective of the patients. 5 PROMs: physical health, mental health, social functioning, well-being, and general health, and 5 PREMs: trust, quality, person-centered care, experience coordinations, and confidence to self-manage. In this diagram, you see in the light blue would be the minimum score that countries got for those indicators. Dark blue would be the maximum score that countries got for those indicators. And the OECD average, the average of the countries that participated in the PaRIS survey is in green, is in orange, sorry. So what we see is that sometimes we tend to measure health systems performance through life expectancy, some indicators that we feel that they've reached to a plateau and that we can't improve more. But if we look at the PROMs and PREMs, there's still room for improvement, as you can see in the diagram. Okay, so now, as family doctors, as I've mentioned before, we look at the results from the perspectives of primary care physicians, general practitioners, and what we know through PaRIS and what you know from your everyday practice is that multimorbidity now is the core business of primary care. So the majority of people, 45 years or older, live with one or multiple chronic conditions. So 82% live with at least one chronic condition, 52% with two or more, and 27% with three or more. So 8 out of 10 have at least one chronic conditions, half of them two or more, one quarter three or more. And over 70% of those people who live with multiple chronic conditions take at least 3 medications, and more than a third take 4 or more medication. And if we look at disaggregated data by gender, we see that women, for instance, report more arthritis and mental health conditions, and men, on the other hand, lead in hypertension and cardiovascular conditions. So when we look at people living with chronic conditions, that's pretty obvious, but we could somehow quantify through the PaRIS survey. Its additional chronic condition deteriorates people's social life. So we saw the same pattern from different prompts, from different indicators: physical health, mental health, well-being. But what you have in the slide is social functioning, which is basically the way that people can deal with their everyday life, the way they socialize, the way they can go to work and do their work properly, spend time with their family, with their friends. So each additional chronic condition means that your score for social functioning decrease significantly, especially between 2 and 3 or more chronic conditions. And we also looked at the impact that mental health can have in people living with multiple chronic conditions. So here in the slide, you see same indicator, social functioning. The dot means 2 or more concordant conditions without mental health. Concordant conditions is basically chronic conditions that have the same mechanism. For instance, hypertension with diabetes, with chronic kidney disease, with cardiovascular disease. So I feel that healthcare systems are already in pretty good shape to deliver good quality healthcare for those people. But when we add a mental health condition, as you see, the impact on social life deteriorates significantly. And in some countries, we see losses decreases in this indicator of more than 30%. And what does PaRIS tell us about how healthcare systems perform? So one very interesting finding that we saw through PaRIS and using OECD data that we had on health expenditure is that spending more does not necessarily mean better healthcare. So we've got countries like Switzerland, Norway, the US that they allocate a lot of resources into their healthcare systems, and patients report high levels of experience quality. But on the other hand, we see other countries like Czechia or Slovenia that they may not allocate that much resources, but maybe in a more efficient way, like the resources that they allocate into the health system, they allocate in primary healthcare. And they, as you can see, they also score above the average, with the example of Czechia scoring really, really, really high, with let's say lower percentage of health spending allocated to health. Okay, and now we are going to touch on a couple of things that will resonate with your everyday practice. So PaRIS reveals that most people with multiple chronic conditions have limited consultation time. So if you look at the light blue bar, those are people that reported that had less than 50 minutes or 15 minutes of less consultation time. So if we look at the OECD average, about 50% of people with multiple chronic conditions are managed in practice with consultation time of more than 15 minutes. So there's, as I've mentioned before, there's still room for improvement here. And some countries like my country, Wales or the Netherlands, there's more than 90% of patients that report having consultation time or 15 minutes or less. And also, it's not only the time that patients have for the consultation, but also the fact that most patients do not have a long-time relationship with their primary care professional, what we normally describe as continuity of care. So again, on average, about 60% of people have been with the same primary care professional for more than 5 years, but there's the other 40% that doesn't. So again, we look at the light blue bar and we see those countries here, Saudi Arabia, Greece, Spain, that were more than half of the patients don't report having a relationship with the primary care professionals of more than 5 years. So it's consultation time and also a relationship with the same primary care professional. And this might influence patients' trust in the healthcare systems and also in their healthcare professionals. So we see that coming back to the continuity of care indicator, that building trust with a primary care professional who knows you and who knows your history is invaluable for managing your own health, especially with chronic conditions. So you see that the longer the relationship with your healthcare professional is, the more you trust in your healthcare professional. And there's a clear difference between less than 1 year and more than 10 years. So this is what builds trust, but we've got other things that diminish trust, like, for instance, waiting times. So we saw that if you get a quick appointment, and like by a quick appointment, we mean the same or the next day, the percentage of patients who trust the healthcare system is more than almost 70%. But if your appointment takes more than a week, it would be around 57, 50, 58%. So again, it's 10 percentage points of difference, on depending when you get your appointment with your primary care professional. And also having to repeat your health information that we expect that should be in the medical records that our primary care professionals have. So people that went and see the doctor and didn't have the need to repeat their health information, they saw higher levels of trust compared to those people that needed to repeat information because they were seen by a different professional and they had to go back to their medical history, telling he or she the treatments that they were having for their medical conditions. So yeah, repeating your health information diminishes trust because you feel that the fact that you are being seen by a different professional is not definitely beneficial for you. So in what ways can family doctors make an impact? Obviously, we should advocate for longer consultations. We should advocate for longer relationships too. But we can also do things in our daily practice. So family doctors, we can empower patients to live well with chronic conditions by providing education, by providing support, and encouraging self-management. So here we look at one of the PaRIS 10 indicators, which is confidence to self-manage, which means the confidence that you have in managing your own disease. If you are somebody with hypertension or type 2 diabetes, it means how confident you are in managing that hypertension or that type 2 diabetes. So if the primary care professional offers you self-management support tools, you may be more confident in managing your own health. So engaging with patients with education, engaging them in their decisions through shared decision making is going to be beneficial because then patients will be more confident to manage their disease. And again, this is pretty much the same, but a good family doctor addresses your needs and makes you a partner in your health. So before we were referring to doctors who give self-management support tools. Here it's been in getting our patients involved in the decisions that we and they have to take. And again, the level of confidence in self-management is higher if we engage our patients in their decisions. And we also found that reviewing medication was very interesting because it improved significantly care coordination. So here, another indicator of the PaRIS 10 is experience care coordinations, the way that patients feel that healthcare is coordinated in in a way that meets their expectations. And yeah, when patients review their medication, they reported higher levels of care coordination. So we definitely encourage family doctors, nurses, community pharmacists to do this thing periodically, because we found that patients reported higher levels of care coordinations when this was done. Okay, and well, to conclude, this is a bonus, and it's about the role of digital health in family medicine. We've recently done more exploratory analysis, and some of these graphs are already in the PaRIS flagship report that I mentioned before. But it's also quite interesting now that we are talking a lot about digital health, AI, and whether the patients have to be digital health literate, whether the health workforce has to be digital health literate. So we measure digital health literacy in the PaRIS survey, and we did it through the eHealth scale. And basically, we were asking patients this question: how confident are you in using information from the internet to make health decisions? And we were taking the first two, very confident or confident, and only 19% of those patients were confident in using information for the internet to make health decisions. So yeah, there's 8 out of 10 that still they are not confident in using information from the internet to make health decisions, and we assume that can translate to using relying on other solutions, other apps that you can find in your smartphone or wearables or things like that. And when we look at digital health literacy, we have to also acknowledge that normally younger and more educated people have better digital health literacy. So if we are expecting our patients to deal with digital health tools, IT tools, digital health solutions, we have to make sure that introducing digital health tools is not going to widen inequalities. And we have to take into consideration especially people that are lower educated and also older people, that they are also and double check that they will be also able to use these solutions properly. Because as we also saw in the PaRIS survey, lower educated people normally struggle more to use their primary care practice website. So the indicator that we are analyzing is the percentage of people or patients that said that the primary care website was easy to use, to get an appointment, to get the results from a blood test or X-ray. Yeah, so here, obviously, as you can imagine, the lower education means more difficulties. So yeah, as I was mentioning before, we have to definitely take into consideration this group of people so that they also can beneficiate for these digital solutions. So we also saw that fewer than 1 in 10 patients with chronic conditions report having used video consultation services with their primary care practices. So yeah, that was a bit surprising to us. And only in Australia, we had like more than 30% of the patients. The normal thing is still face-to-face or phone consultation. But then when we looked at the difference between face-to-face consultation and remote consultation, and we ask patients how much you trust the healthcare professional, well, depending on whether you see him or her face-to-face or remote consultations, there was no significant difference. So remote care services to us were not significantly less trustworthy than face-to-face care in most countries. So I think it's not going for face-to-face or going for video consultation, but making sure that the option that we decide is going to provide patients higher standards of quality. Because if they perceive that high quality, they will trust face-to-face remote consultations as much as face-to-face consultations. And the last slide on PaRIS results is that we saw that 90% of patients that are managed in practice use electronic health records, and in all countries it's almost 100% if you look at the dots. But then we saw that they were not systematically shared. So there's still a big issue with interoperability, sharing electronic medical records in most countries. There are some countries that are performing very well, the Netherlands, Belgium, Norway, Australia, but the majority of countries, and if you look at the OECD average, it's only 50% of the practices that use and collect electronic records are able to share them properly. And that's also for us a big area to focus, because we would expect and we think that it should be close to 100% for all countries, because that's the interoperability of electronic medical records to us is crucial for the coming years. Okay, so the conclusion, it's multimorbidities is and will be our daily practice, our core business, and I think that's where we have to focus most as family doctors. We knew that, but we could somehow prove it, that continuity of care builds trust and improves outcomes. The importance of engaging patients in decisions through their decision making, for instance, it really makes a difference, and patients feel more confident in managing their oral health conditions, and they report better outcomes. And then looking for these interventions like medication review that improve care coordination. So we now see that patients do value a lot that a healthcare professional, GP, nurse, community pharmacist review its medication, and that digital health is not going to replace doctors, it's not going to replace the nurses, but we should see digital health as an enabler and embrace it and try to make good use of it, because as we saw patients are, I think now in a moment that they are still to see it as an enabler as well, and if the quality of care that they feel it's being provided of high standards to them, they will trust it as much as traditional forms of healthcare delivery. So
Thank you so much, Angel. I believe it's super interesting and very practical for GP. So I think now everybody is, very glad that if you have time and you have a long trust relationship with your patient, it's going to be the best for everybody and it's going to be a win-win. So thank you so much for sharing this super study. And it's also very nice to see that you have the resources to do such a big study with 19 countries, nearly 2,000 practices, more than 100,000 patients. So, it's not just like one small place or one country, but this is like something across the whole region. And so I think that's very interesting. So we are going to answer a few questions. If you have some questions, you can put it in the chat, or you can put it in the questions and answer, both of them. And after that, we are going to talk to Candan about the future, because I think now everybody is just like curious how to get involved and, how to see your practice in this big picture and what can we do with this kind of data and all these interesting insights that you have shared. So the first question is from Mary McCarthy, and she says, is digital health disenfranchising those who are not digitally literate? So I don't know what's your opinion on this, because you have shared a few slides about the situation of people who have less resources or less education and how they are going to approach digital health.
Thank you for the question. I think that what we've found through the PaRIS results is quite clear. I think that the majority of the population is still they don't rely on the information from the internet to make health decisions. And it's not that we want 100% of them to rely on information from the internet to take health decisions, especially now in the area of ChatGPT and artificial intelligence. But I think that what we see is digital health as an enabler, both for patients and for doctors. There's so many innovations now going on, and I think that they can solve a lot of issues that primary healthcare systems have, for sure. But at the same time, we feel that that has to be a process where both the health workers and the patients go hand by hand and go in the same direction. And we definitely have to take into consideration, as I've shown in my slide, elderly people, people with lower levels of education, that first of all, they may not have access to these fancy solutions. They may not have like an Apple Watch or an iPhone or a smartphone. And if we are offering this solution because we are offering these solutions to patients that can use, and we see that it's working properly, we have to make sure that if we offer the same solution to them, we are going maybe to take a closer look and follow more closely how they are doing with it. And also, I think that it's very important that the primary care workforce is also kind of upgrading their digital health skills so that they can also provide good advice, good recommendations, good solutions based on a clear knowledge of the situation.
Yeah, absolutely agree. So the next question is from Maria Pilar Asier, and she says, what recommendations from PaRIS report could you suggest to the European health ministers to improve primary health care? So come on, let's go for changing the world. Thank you, Pilar, for your questions. And for example, she shares a few examples. Allocate more time for doctors, patients encounter, particularly when patients with multimorbidity and polypharmacy. Or what will be your recommendations after reviewing all this data and having these conclusions? What can be implemented in the short time, I would say, and maybe in the long time?
Yeah, I mean, thank you, Pilar, for the question, by the way. I'm looking forward to seeing you next week. I think that, I mean, yeah, as family doctors, for me, yeah. So both Jan and I, we wrote together the chapter on multimorbidity, and we looked at this thing on continuity of care and time per consultation, and I think that that's super important. So yeah, I've practiced in Spain a few years ago, and yeah, and I think that at the end it makes a big difference if you have 15 minutes for your patients compared to 8 minutes. That may be the normal situation in Spain, because yeah, you feel that you can listen to them, you can because patients at they don't come with only one health problem. They normally come with two, three, four. So yeah, we shouldn't be rushing on them. So I think that yeah, time per consultation is crucial. And if you want to build a relationship of trust, not only with your patient but with the whole family, you have to be in the same position for, I mean, a long period of time. I mean, we saw that patients when they have to go to the doctor, to the nurse, and they see a different professional, and they have to repeat their medical story, their medical history, their treatments, that diminish trust, because they feel that, and for them, I think it's also a bit frustrating okay, yeah, I've been with 6-9 months with this professional that was listening to me, knew my story, knew about my husband, my children. Now I have to go back and repeat the same information again. So yeah, for me, it's time for the consultation, and time for establishing a good relationship that's gonna make a big difference.
Yeah, just sharing, we learned a few months ago that in Denmark, in case you have a mental health disease, you have this like 45 minutes a year to dedicate to this patient so you can address all their needs and you are not in a hurry. So I think it's just like a good strategy to these kind of complex patients, that you know that at least once a year you can have extra time to address everything, to review medication and to listen to their concerns properly and not be in a rush. So I'm just sharing this because sometimes there is hope that some of the Ministry of Health, they make some innovations that are positive to the patients and to everybody else. And so now I would like just to make Candan join the conversation. And if you can explain us a little bit about, what is the future for PaRIS study? How can we connect if we haven't connected to this study? If you are going to do more waves in the future, and which is the future, or, the practical insights for this study. So I pass the mic to you so you can share all the news before the workshop. I'm just telling you in the middle here that on Friday during the Wonka World Conference, they will be having one workshop and, one symposium, I think. And it's going to be in the main auditorium early in the morning, 9 to 10. You will be able to meet Angel and say hello to him. I promise he's super nice. I'm very enthusiastic, so it will be very worthy to listen to him. And also they have some of the findings of the study is a little bit more detailed. You can also listen in the whole 106 on Friday from 5:15 till 6:15. And there is also a short presentation on Thursday of the results of Portugal. So if you are curious about what happens in only one country, Portugal, it's going to be on Thursday at 9:20. So there are several opportunities to engage with this study and with these researchers. So please join us next week during the World Conference. And now I pass the mic to Candan. Please tell us, what is the future?
Thank you, Sarah. And thanks for all these questions. Actually, what I'm going to say is very related to what we have been discussing about how to use these results so that it makes sense for policymakers to incorporate patient-reported outcomes and experience measures to improving primary care. So in the very near future, let's say, what we are aiming for is to use the results, because we had so much data. What Angel showed today in his presentation is just a small part of what we publish in the flagship report. And in the flagship report, we just scratched the surface actually. So there is enormous data that we still need to explore, and also for countries as well. So we have our international data set where we have data from 19 countries, but each country has its own national data set as well that they can explore a bit further. So our near future plans are really focusing on this aspect of using the results so that they really make sense for primary care policies and the practice as well. And afterwards, PaRIS was never built as a one-off survey. It was always built as a survey that will be implemented systematically in the countries so that patient-reported outcomes and experience measures become part of performance indicators. Because so far we have been using kind of indicators about avoidable hospitalizations, avoidable mortality. This is how we measure the performance of primary care: number of general practitioners, number of nurses, other healthcare professionals, number of screenings, number of vaccinations. So these were really focusing on the actions that we were taking or the inputs that we have in the healthcare system. And here what we are trying to bring is, and all these indicators are helpful. I'm not saying that we should get rid of everything and then just implement outcomes and experience, because this will be, again, like not complete. So what we are trying to do is do these systematic rounds of surveying with the PaRIS data and incorporate it in the performance measurement across the countries. The next cycle, so every cycle takes 5 years, and it seems too long, but we are already rushing to be on time for the data collection, because it's a huge endeavor. It's not just one survey that we implement over the night, but we are really trying to build this, co-develop this with 10 patient organizations advising us on every step, primary care professional network involving several colleagues from WONCA as well, an international expert group who are experienced in international research, primary care research, chronic care research. So they are all advising us. And all these instruments that we are developing and the design of the survey are field tested in the participating countries. So the next years will be very busy with developing the second design and also reviewing and revising our instruments to prepare for the second cycle. And then the data collection will take 2028, 29. And then we will have the next flagship report, hopefully in 2030.
Wow, it seems it's like you have a plan, a big plan, very well organized, with everybody is on the plan. So how a normal family doctor can interact with you, can participate in this study, or can follow your updates? So can we really interact with you?
Yeah, I think there are several ways of doing this. So the first level is what's happening at the national level or international level. So contributing to policy making or advocating for family physician, family doctors, or primary care in general. So this might be the first thing, engaging with national organizations and making sure that your country is participating in the second cycle, because this is not a mandatory task. Countries need to volunteer for it. And the decision comes from Ministry of Health. So if you have a national organization, make sure that you are part of the conversation at the national level and advocate for participating in this second cycle. The second thing that you can do, if you have some research interest, research expertise, now we are preparing scientific use files. So everything we collected from the first cycle are prepared in an anonymized way and will be available for researchers who will hopefully, we hope that they will be helping us to explore further what really makes sense, what we can get out of it, how we can bring recommendations to policy and practice that will help us. So this research background also becomes very important. And Wonka Europe has very good networks for this, like EGPRN. And the last thing is when it comes to an individual family doctor practice. So to participate in the survey, to answer the survey, you should be part of a sample because we are going for a random sample in the countries and we don't know if you will be contacted or not. It's the national project management team who does. If you receive the invite, I think the easiest thing that I could say is participate, respond, make your voice heard, and make your patient's voice heard. That will be the easiest thing to do. Let's say that you don't receive an invite. What you can do is you can use some insights, right? You cannot use the PaRIS survey, but the insights from it. Pilar was mentioning that, for instance, in the chat, if you have the possibility to play with your consultation time, make sure that you take time for very complexity leaves. This might be multiple chronic conditions. This might be people with mental health conditions, but might be also some sociodemographic characteristics. So make sure that you have this. Also, where the continuity of information lies, we saw that we can build several things like trust, which is very important in our practice as well. I think this insight is also very relevant for the daily practice as well. So we can use some insights from the PaRIS for the individual family doctors practice as well.
Yeah. I have another question. How do you relate to other stakeholders like WHO, like the Observatory of Health, like different Ministry of Health? Now you have all this interesting study that, in my opinion, is very relevant for primary care. So how do you engage with another stakeholders to make this situation or positive aspects of primary care in the from and friends of the patients? And, what it has also been the answer from these stakeholders?
There are two main levels, I would say. The first one is the established one. As I was saying at the very beginning, we have these stakeholder groups where we have international expert group, for instance, where we have people from observatory as well. Now we are talking with Commonwealth Fund, with some international surveys who look at the same question. So we really try to brainstorm together to see what are the gaps where we can answer it together, how we can collaborate with each other, because we are trying to answer the same question. And we are trying to do it with different organizations like primary care professional patient organizations. When it comes to countries, we always say that it's an OECD study, OECD does that, but actually we are just a secretariat for our member states. We have 38 countries, member countries, as Angel was mentioning. So basically, they are the ones who take decisions about everything related to PaRIS. So the final questionnaire is something that is validated and approved by member states through their delegates to the OECD. And this is how we collaborate with our ministries of health, with the national bodies who are involved in the implementation of PaRIS at the national level. And on top of that, of course, we have some ad hoc contacts whenever it's possible with colleagues from WHO, with other organizations. There will be a quality event in Athens in October where we will also present the PaRIS results. Because what we are doing at the international level is actually just to make sense at national level. And for countries, for ministries of health, there are several bodies, international bodies, who can help them for the same question. So it's very important that we collaborate with each other. We always communicate with each other so that what we are saying makes sense for them and is relevant for their context as well.
Yeah. So thank you so much. That has been very interesting. I'm also inspired because I think sometimes as family doctors, we are very concerned with the budget. And, after listening to your results, the budget does not seem to be the main component of the good outcomes for the patients. So it gives us a little bit of hope, at least to those who are not in super high income countries. So I think that's a very good result. And also that, I was just very surprised to listen the results from Czechia and Slovenia and how they have invested in having more consultation time and more longitudinal relationship with their patients. And so they have better outcomes in general. So it's something that all of us can do, and also all of us as family doctors can build. So I really don't want just to spend much more time, because I know people can connect with you in real life in Lisbon, and it's going to be amazing. So I just would like to close with one, one lesson or one inspiring sentence for the family doctors who are here. And I guess they have, lots of things to reflect and to share tomorrow in coffee's time at their practices. So if you can, both of you, just give a few sentences as a conclusion or recommendation or whatever you want to say, you are very welcome just to say before closing.
Yeah, yeah. I mean, I'm gonna take what Pilar mentioned in the chat, and I completely agree with her that, yeah, I mean, on top, yeah, it's also very important, the dedication. I think that, and somehow it can relate to a couple of slides that we've presented. The one of engaging patients in their decisions, the one on yeah, offering self-management support tools. So sometimes, and I've been in that position, even though I'm not practicing now, but yeah, yeah, sometimes, yeah, I remember 5, 6 years ago when I was practicing in Spain, that, yeah, 25, 30, 35 patients in the morning. Yeah, maybe sometimes you just want it. I just wanted to have a diagnosis and maybe a treatment so that we could get things done. But we see now that the dedication makes a difference, and if you explain your patient what he or she has, the different treatment options, what he can do, what he can't, what he or she can't do, or I mean, I think that makes a difference, and it's not just okay, you've got this disease, take this drug. So for me, yeah, it's definitely dedication, or because it's a very complex situation, but I think that that's something that we can't take for granted, and we have to definitely reflect on to what extent we are doing that. But I'm sure that everybody's doing a great job.
Thank you so much, Angel. I think this is a very good conclusion. And Candan, what would you like to add to Angel's words?
I think I would say make your voice heard, because in primary care, we also you practice actually, in the constraints of healthcare system as a whole. So whatever we say for practice recommendations, like increase the time that you spend with the patient, increase coordination, the digital health tools, you need to do some things at the system level. So it's not possible to implement everything at practice level and change everything. Of course, this is important. Dedication and motivation is important, but you have the constraints around you. So it's very easy to get frustrated, disappointed, have burnout, feel bad about practice and everything. But if you share, if you seek for solutions, if you reach out to your organizations, to your colleagues at the international level, we have this network, even to us, to share your views about the results of this survey. I think this will also help with staying calm and helping with progressing things. Sometimes it will be very slow, sometimes it will be fast, sometimes it will not progress at all, but at least you will feel good at the end of the day. So I would say make your voice heard.
Thank you so much. That's a good advice. Thank you also so much. We love just to have family doctors in different levels. And so having both of you at the OECDC, at least to myself, and I think to the whole audience, probably is going to make them feel very proud to have, all your work and to see how you are caring about everybody who is working in primary care, and especially to the patients. So thank you so much for your work. We really appreciate you. We are looking forward to meeting you. And my last words are for Burak, because we couldn't do this record and this wonky talk without his support. He has been amazing, as always he is. And so thank you so much, Burak. And I would like to wish all of you a lovely evening. Please enjoy your time, relax your time, don't think about negative things, and please get inspired about after this session to improve the care to your patients, and also to be proud of your job. As Candan says, you are very important, your voice is very important, and we really count with you to improve patients' health in this continent. So thank you so much. Have a nice evening, everyone. Bye bye.
Have a lovely evening.